Good afternoon. I'm Allie Coates. I'm president of the board of directors of the New York State Association for Rural Health. Thank you for joining us for today's discussion on the New York State Comptroller's Report, Shortages of Health Professionals in Rural Areas. Before we get started, we'd like to share a couple of upcoming opportunities. First of all, there is a call for abstracts for the 2026 Public Health Partnership Conference, and the abstracts are due on November 13th. Topics for presentation range from workforce development, data, technology and AI in public health practice, public health policy implementation. We hope to see you in Lake Placid on April 22nd through the 24th. Next, we invite you to join us virtually for National Rural Health Day, which is on Thursday, November 20th. We'll have our awards ceremony at 10 a.m. These awards recognize innovation, dedication, and the people who are transforming rural health across our state. And then later in the day at 1 p.m., NYSAR will host speakers from the National Rural Health Association who will provide a federal update to better understand how the current decisions are going to impact our healthcare. CHES credits will be provided. Now, on today's important topic, New York State Comptroller's Report, Shortages of Health Professionals in Rural Areas. This report captures the reality that rural hospitals and providers have been navigating for years, persistent workforce challenges that directly impact access to care and the sustainability of services across our communities. Today's conversation is about understanding those findings and identifying practical paths forward. We're fortunate to be joined by two leaders who bring deep expertise and perspective to this issue. Erin Fraher, PhD, is a professor at the University of North Carolina at Chapel Hill Department of Family Medicine and director of the program on Rural Health Workforce Research and Policy at the Sheps Center for Health Services Research. She also directs the Carolina Health Workforce Research Center, which is one of 9 HRSA-funded centers for health workforce research. Dr. Fraher's research focuses on graduate medical education, interprofessional teams and new models of care, workforce projections under different possible futures, and using life course theory to better understand health professionals' career trajectories. She has served as an expert advisor to the National Academy of Medicine in multiple roles and is the immediate past chair of the Council on Graduate Medical Education, which advises the Secretary of the U.S. Department of Health and Human Services and Congress on workforce trends, training issues, and financing policies. Dr. Fraher was also reappointed to the 2025 Congressional Budget Office's panel of health advisors. We're also joined by Joshua Simmons, Policy Director in the Office of Budget and Policy Analysis at the New York State Comptroller's Office. Mr. Simmons has 17 years of experience in policy analysis, holds an MPA from Marist University and a BA in Political Science from SUNY New Paltz, and brings valuable firsthand perspective as a resident of a rural Ulster County community and volunteer first responder. Together, Dr. Fraher and Mr. Simmons will discuss the data, the key findings, and the implications for rural hospitals and providers across New York. After their remarks, we'll move into an audience Q&A, so share your questions in the chat at any time during the presentation and we'll address them at that time. So thank you so much. We'll start now with Joshua Simmons.
Thank you so much for the introduction. Let me just share my screen and we can get to the presentation. Okay, so back in August, we had released a report on rural health professional shortages in New York. This report focused on 16 rural counties. It's not a complete list of the rural counties in New York, but a sample, as many of the issues faced by these counties are faced by all rural areas. So you can see right here, there's a list: Hamilton, Essex, Lewis, Franklin, Delaware, Herkimer, Allegheny, Shenango, Schuyler, Cattaraugus, Steuben, Wyoming, Washington, Yates, Greene, and Sullivan. So these were primarily chosen by population density, but there were some other criteria which were in the which I detailed in the report. Probably not important to go into here now. So the main findings were that there are pretty severe shortages of healthcare professionals in rural New York. I'm sure this is no surprise to anyone here. But in primary care, for instance, the 16 rural counties had 4 primary care physicians per 10,000 people. This is less than half of the state ratio, and it was below We had compared these to the Geminac guideline. I know that it's very old and outdated, but it was the only epidemiologically derived projection of need that I could find with regards to physician to population ratios. Interestingly, the family and general practice physicians were pretty much on a par, the state, rural counties, and the guideline. And then there was also a severe shortage of pediatric physicians, which are a subset of primary care. There were 172,818 people within designated primary care health professional shortage areas. Those are designated by HRSA, who were underserved. And that was 23% of the 16 rural counties that we looked at population. The most acute was as low as 0.12 physicians per 10,000 people for the designated population, which I believe was the Medicaid eligible population of Washington County. So the 16 rural counties have basically half a pediatrician for every 10,000 people, less than 1/5 the state ratio, and 1/3 of the ratio for the US. Physicians assistants and nurse practitioners, because we know there's a lot of substitution that goes on within primary care, particularly in things like urgent care settings, were much lower than the statewide ratios. And mental health practitioners were far lower than the state ratios. In terms of healthcare professional shortage areas, so this is a map of the HRSA HPSAs for primary care, including the HPSA scores. You can see that they're pretty much all over the rural areas of New York, and we were definitely in the 16 counties that we looked at. In terms of maternity care and reproductive health, we found that there was a pretty severe lack of OBGYN physicians in the 16 rural counties that we looked at. The ratio was 0.4 OBGYNs to 10,000 population. And this is the New York State average was 1.7. There were, 4 counties within the 16 counties that we looked at. So a quarter of the counties that we looked at had no OBGYN physicians. That was Hamilton, Herkimer, Schuyler, and Yates. And then in terms of the maternity care target area scores, this is a subset of the HPSAs. There were some pretty severe shortages. Sullivan County popped out as among one of the most severe shortages. Oh, this is mental health. I mixed up my maps. This is the mental health HPSA scores and not the maternity care map. I'll come back to that. So in terms of mental health, based on the number of counties designated as mental health HPSAs, the total underserved population, and the HPSA scores, the mental health professional shortages in the rural counties may be the most severe shortage faced by New York. The ratio was far less than the state average, and all 16 rural counties that we looked at were designated as mental health HPSAs for either the entire population or portions of the population, such as the low income or Medicaid eligible population. In the 16 rural counties, there are 300,265 people within mental health PHCs who are designated as underserved by HRSA, nearly 41% of the population. And so that is not the maternity care target area scores map. That is the mental health HPSA scores. Sullivan County in particular pops out as one of the worst in the state. So for dental health, this is another area where there were pretty severe shortages. The ratio of dentists per 10,000 people was less than half the state average, indicating that the shortage of dentists is not just limited to those accept Medicaid, because we had heard in some listening sessions that we had done in rural areas that there was a shortage of Medicaid eligible dentists, which there is. There are no dentists in Hamilton County, and some of the rural counties had extremely low ratios, even when compared to the rural average. 10 of the 16 rural counties were designated as health professional shortage areas, and with 134,248 people designated as underserved. The formal ratios ranged from I don't think that's terribly important, but the number of people per dentist in the underserved designated areas ranged from nearly 10,000 in Greene County to over 100,000 in Franklin County, which is the equivalent of 0.09 dentists per 10,000 people. Now, the the formal ratios are formulaically derived, and so there aren't 106,000 people in Franklin County. It's the physician, it's like the dentist per population ratio. And because it's a weighted number, populations with higher needs are scored higher, and therefore the numbers appear larger. So this is a map of the dental health professional shortage areas. And the impact of federal actions. Well, the lack of providers and physical facilities in New York's rural counties present an additional barrier to recruiting healthcare professionals. So if there's no place for professionals to practice, it is difficult to recruit professionals to practice there. Not all counties have hospitals or rural health clinics, and those that do operate on tight margins are at a loss. Reductions in the eligibility for Medicaid and the Essential Plan made in the federal reconciliation bill may further exacerbate the issue, potentially forcing some rural hospitals to close. New York State has 6 rural hospitals that are in the top 10% for Medicaid payer mix throughout the nation, and an additional 5 that have experienced 3 consecutive years of negative margins. In the rural counties, there's over 200,000 people, or 27% of the population, enrolled in Medicaid as of May in 2025. And it's unclear to what extent the impact of Medicaid cuts on the rural healthcare system will be offset through funding through the Rural Hospital Transformation Program. I know that that's been in the news a bunch lately as the deadline for the application is coming up. One thing to note is that, for instance, for the pediatrician shortages here, this data is from HRSA's area health resource files. And so that is the pediatric physicians are ones that have undergone residency programs in pediatrics. I know that there are health providers who have, say, family practitioners offering pediatric services, and they're advertised as such. And so in Cattaraugus County, I believe there are 2 physicians who are providing pediatric services, but they didn't show up in the data that we were using there. So let's see. Potential solutions, not to step on the toes of the presenter coming next, but we had suggested that expanding public transit and paratransit could assist in being able to get people to doctors, expanding telemedicine to be able to bring doctors into people's homes is a potential solution, although with disparities in broadband access in rural areas, there are challenges that come along with that. There have been some success in offering mobile clinics to be able to bring healthcare closer to people, school-based health centers, loan forgiveness programs to encourage more professionals to serve in rural areas, and the establishment of a nursing educational pipeline. One of the things that we found is that the ratio of RNs in the rural counties that we looked at was actually much higher than the state average. We speculate that could potentially be because RNs can receive training at community colleges, which are dispersed throughout the state and relatively close to people. But the nurse practitioners, for instance, is much lower. And so if there were a way to create an educational pipeline whereby to incentivize RNs in rural areas to pursue nurse practitioner training, then they might be part of a solution to sort of plug these gaps. Thank you.
Thank you so much, Mr. Simons. Next up, we have Dr. Fraher.
Thanks very much. I'm delighted to be with you all this afternoon. And I think what I like to do with my title is give you the entire gist of my presentation. And so one of the reasons I'm so delighted to be speaking with you today is part of the themes I'm going to say is if you look at where workforce policy is going, it's going to the states. And the states will be an even more important locus for policy change to address workforce issues in the coming years. So let's talk about that. First, I just want to disclose that I am funded by HRSA and by our AHEC program. My opinions are not their opinions, so nothing I say should be attributed to them. And just always hugely grateful to the incredible team I get to work with here at Sheps. I also do a lot of presentation to legislators, and I like to give them the bullets right up front. So if your phone rings, your dog barks, your dentist calls, here you are. The physician shortage narrative really dominates in the United States, but it's really, I like to take that physician shortage narrative and turn it into, can we talk about the maldistribution of physicians and other healthcare workers by specialty, setting, and geography? That really, to me, is the pressing issue and why I was just delighted to be invited by you today. And those disparities between our well-resourced and our underserved communities are growing. I'm going to show you evidence of that from North Carolina. We're going to talk about why I believe states will be an even more important locus for health workforce policy in the next few years. And one of the things, because I really do believe this with my heart and soul, I want to talk to you about the importance of building health workforce data infrastructure, because then you really arm your decision makers with data instead of anecdotes. Anyone who's been to the legislature to listen to a health workforce policy debate has heard a lot of anecdotes, and it really helps to be able to get some data in there. So here are the 4 issues we're going to talk about in the next couple minutes. So what do I mean here? If you look at this, the supply, this is the national supply of physicians per 10,000 population in the United States. It has been growing. So that's relative to population. So even though patient acuity is going up, we're still increasing our relative, the number of physicians or the ratio of physicians per 10,000 populations. But New York, North Carolina, Tennessee, California, everyone is feeling short. Why is this the case? Well, one reason is the gap between metro and non-metro counties is really growing. These are data from my home state of North Carolina. What you're seeing is on that orange line, that's the ratio of physicians per 10,000 populations in our metro counties. That green line is the ratio of physicians in our non-metro counties. You can see that that gap was metro counties had about 9.5 more physicians in 2000. They now have 14 more physicians. So even though, remember, we just looked at that number of physicians and that ratio of physicians going up, it's distributionally going into metro areas. And so that gap is not closing, it is in fact widening. And one reason we are required in North Carolina to track our medical students every year, we are required by the legislature to track their retention in North Carolina 5 years after graduation. And so you can see our latest tracking data. We had 628 medical students graduate from our 5 medical schools. 55% of those medical students matched into a primary care residency. A chunk of those were internal medicine residencies. So 5 years later, in 2024, only 10% were in primary care in North Carolina, and less than 1%, 5 physicians of those 628 were in primary care in rural North Carolina. This is a huge, huge issue for us because we are trying very hard through our medical schools to expose students to rural practice. But we also do know that residency training matters, that residency training is a higher predictor of where a physician will end up in practice. And we also track where our North Carolina residents end up in practice. So what you're looking at, let me explain what you're looking at. You're looking at cohorts of residents who graduated from North Carolina medical schools in 2017, 2018, and 2019. And you're looking at where they are 5 years after they graduate. Each box in this graph is a resident. So you can see internal medicine residencies graduate the largest number of residents, then family medicine down to IMPs. So what should you take away from this chart? Look at the retention of family medicine in state is about 50%, right? And 11% in family medicine stay in rural communities. That's quite significantly larger than, for example, the 39% retention of internal medicine, and only 2% of internal medicine physicians end up in rural communities. Look down at psychiatry. Only 1% of our residents trained in psychiatry ended up in rural North Carolina. So the way that we use these data, to be honest, is to really help the legislature understand that these investments going into UME, undergraduate medical education, and GME need to really be much better targeted and expand residency training in rural communities, because that actually is what's going to make the difference. And we know that medical students who do both medical school and residency training in the state are much more likely to be retained in state. So if the overall retention rate is 37% for all of our residents, it goes up to 65% if those residents did undergraduate or medical school in North Carolina. So really speaks to that important pathway between medical school and residency training as a predictor of which medical students. And this is, I'm showing you data from North Carolina, but this is shown repeatedly through other states as well. So let's talk about this recent shift toward more state-led innovation. I got started to think about this. Anything you read in the newspaper, actually, you can see a lot of what political scientists call federalism. It's this notion in health workforce policy and vaccine policy and all sorts of health policy that the responsibility for shaping the size, the distribution, the composition of the health workforce is really a responsibility that is shared between federal and state governments. And each level has its own responsibility and authorities, right? So the federal government is in charge of visas. They invest a significant amount of dollars in graduate medical education. But the states actually have responsibility for scope of practice, for Medicaid policy. And so you end up with this interesting thing where New York, North Carolina is sort of navigating what's the state's responsibility, what's the federal's responsibility. So as you're taking away from this webinar, it's really important to think about what are the policy levers within your reach as a state and how do they intersect with federal policy. I would say it's a great time to be thinking about state health policy because there's been a real shift. And that argument is that states should, in fact, be engaged in health workforce policy because it gives you more flexibility. It allows you to innovate. Your population in New York is very different than the population in Idaho or even in California or North Carolina. So this notion here is that states are incredibly important. And if you look at the introduction of health workforce policy bills at the state level, they've more than doubled compared to where they were even last year. So Mr. Simons mentioned the Rural Health Transformation Program, and I've actually been looking at it and studying it as an example of federalism. And why do I say that? Is if you look at what the RHTP is trying to do, it's trying to spur states to design and implement strategies to promote workforce development, right? Workforce development is one of those 4 pillars of trying to bolster our rural health infrastructure. One of the things that strikes me as I read the notice of funding opportunity is there's a very strong focus on accountability. So half of that funding that states will receive is adjusted based on the state's performance on certain metrics. So that's really saying you got to show us that whatever activities you're doing are actually working for us to give you additional funds. And one of the things I think it's really important to recognize is this question of whether states will then invest in these activities and whether they'll evaluate them to be able to determine which initiatives are actually working and should be emulated and scaled by other states or by the federal government. So likely New York's been a leader in so many areas. What is it that you're going to take on that North Carolina, that California, that Tennessee, Alabama are going to look at and go, that's it, we should be doing that too. I also think the RHTP is going to increase accountability. So those funds that you're receiving from the legislature to build your workforce in New York may be under more scrutiny in the future than it has been in the past. And interestingly, the scoring in the Rural Health Transformation Program really favors states with full practice authority, is participating in the Interstate Compact, has rural training tracks and residency expansion plans, and includes continuing medical education that includes nutrition, behavioral health, and chronic disease. So you can see here some of the important agenda items of this federal administration. And one of the things I'm trying to look at is the degree to which I think the efforts of the Rural Health Transformation Act will in fact reshape state and federal workforce policy. This is fascinating to me, this huge investment in health workforce. How much is it going to shake things up? And like in my own state, in New York, you have full practice authority for nurse practitioners. We do not in North Carolina. So one of my questions, look, this is the relative growth of nurse practitioners in North Carolina. This probably looks similar to what it looks like in New York or in some other state. You know, nurse practitioners have grown 509% since 2000 compared to the physician workforce growing by just 33%. Physicians are still outnumbered. There are twice as many physicians in North Carolina as there are nurse practitioners. But these growth numbers are huge and significant, and any workforce policy is going to have to take into account team-based models of care that incorporate physicians, physician assistants, nurse practitioners, social workers, and others. And I think we'll see some of the Rural Health Transformation Act funding looking at those kinds of things. This is a chart we created because I was super curious in North Carolina where our NPs were going. And so this is relative to 2000 of our total clinician workforce in rural. What do I mean by that? So the denominator is nurse practitioners plus physician assistants plus physicians in rural communities. And you can see physicians used to make up 80% of those clinicians in 2000. the growth of nurse practitioners, the movement of NPs and PAs into rural communities mean that physicians now only make up about a little over 55% of our workforce in our rural communities. So really seeing a distinct difference in the shape and configuration of our rural workforce. And I was really curious, we just did an analysis of our advanced practice registered nurse workforce in North Carolina. And super interesting, what this is showing you is the makeup of our NPs, that first column, in metropolitan counties in North Carolina versus non-metro. And interestingly, family nurse practitioners only make up about 56.1% of the NPs in metro counties, but they make up 73% of NPs in non-metro. So those NPs that are moving into non-metro counties are our family nurse practitioners who tend to have a fairly broad scope of practice and can treat many things in North Carolina. And you see more of our specialty NPs, like our adult gero and our acute care, are much more likely to be located in our metropolitan. So really speaking here to the fact that broad scope family nurse practitioners, family physicians are real stalwart of our rural communities. I became really interested in one of the things Allie asked me to talk about is how I conceptualize federal and state policy shaping the healthcare workforce. This is a conceptual, this is what happens when you ask an academic to talk. You get a conceptual framework, but sorry about this. This will make sense, I promise, I hope. What I'm trying to say here is that you have your current workforce over on that left-hand side, and you have your future workforce over on that right-hand side. So how do you get from your current workforce to your future workforce? Well, here are your levers. You can shape it by shaping the numbers and types of new people graduating your programs, those new entrants. You can shape it through loan repayment, either state loan repayment programs or National Health Service Corps, where they practice that diffusion. Do they go to rural communities? You have a Conrad 30 program, you have the J1 visa program. That's really getting at those levers about where people practice, that diffusion of your workforce. Out of country supply, again, is your IMG workforce, your international medical graduates in the case of physicians, or your foreign trained nurses. Retention and well-being. Look at that arrow pointing up to the workforce. Incredibly important arrow that we forget to put into workforce policy. There is so much that we could be thinking about to retain and encourage our workforce well-being to stay in the workforce. That's incredibly important. We'll talk about that in a minute. And then you have to think about using payment policy and all sorts of other things, scope of practice, to figure out the quantity, quality, and types of services that can be provided. So here we get into scope of practice, interstate compacts, and those kinds of things. And then through all of these policy levers, each of these boxes, or each of these ovals has within them policy levers that you can pull to move from your current workforce to your future workforce. So let's focus on new entrants. So one of the things is that you probably know recently the Congressional Research Service came out with a report showing that we spend $20 billion on graduate medical education through Medicare every year. And that Medicare funding is actually only about 2% of that Medicare funding goes to rural communities. And so recognizing this, the Consolidated Appropriations Act in 2020 actually created 1,000 new residency slots, recognizing Congress saying, hey, look, we have this disparity between rural and urban communities. We really have to address it. Let's create 1,000 new residency slots and try to get them where we need them. Well, bad news. This was an analysis done by one of our master's students and our center director here and others, and Emily Hawes, that showed of the first 100 new residency programs that were awarded slots, 5% trained their residents in rural primary care HPSAs for at least half of their residency, 5%. We did an analysis of the second round of 100 slots. Do you think that it was more successful or less successful at getting training into rural communities? It was, in fact, less successful. In that second round, it was only 3%. So what this speaks to is, even though there have been acts by Congress to try to, Medicare GME is fixed, right? So any change in Medicare GME is going to require an act of Congress. So even recent acts of Congress have really not addressed rural physician workforce shortages. That's the bad news. The good news is that HRSA's graduate medical education investments of recent in the recent past have really increased training in rural and underserved locations. This was a paper we just had in Health Affairs that really countered this narrative that we hear over and over and over again. You can't train in rural communities. There aren't enough, there's not enough patients. There's not enough infrastructure. Well, the number of residency programs with training in rural sites increased from 120 programs in 2008, 2009 to 412. Residencies at our federally qualified health center sites grew from 69 to 321 sites during the same period. How did this happen? This happened because HRSA invested in the Rural Residency Planning and Development Program, which actually provided technical assistance to these programs. So if you knew you were in an FQHC, you were in a small rural hospital, community hospital, and you wanted to start a residency training program, but you weren't sure how to get the pro forma ready for being able to get it funded, you weren't sure how you were going to get ACGME accreditation, you weren't sure how you were going to recruit students or residents, you weren't sure how you were going to hire a program director, this Technical Assistance Center actually went in and helped these places develop their programs and actually has been bolstering. So 21.6% of those rural residencies are, these new residencies are RRPD programs, and 28% of the FQHC-based ones are teaching health center programs. So it matters. You can develop residencies in rural communities. It just takes an investment in technical assistance. And in fact, you in New York have 2 RRPD programs, one at the Auburn Community Hospital Rural Residency Training Track, and the other at the University of Rochester. So this is good news. These are small class sizes, but look, they're both in family medicine doing 55% and 60% of your training in rural communities. One of the super impressive set of rural training programs here, because you're really training people not only for hospital-based practice, but look at the alignment with the VA, with behavioral health. So just wanted to highlight that you in fact you are some of our data in that paper. Okay, so we've talked about new entrants briefly. I want to talk about retention and well-being because I think it's something that we all too often overlook when we're thinking about shaping the future workforce. This is another conceptual framework I developed. This was trying to say, okay, so if this is the pathway of a physician, and you can envision this for a nurse or a pharmacist, right? You have your college education onto medical school, onto residency training, onto your initial practice location, out into ongoing practice. When I sat down to map the policy interventions along this trajectory of a physician, you can see that most of what we focus on, either at the state or the federal level, is very much focused up in that early pathway, right? We've got scholarships, we've got pathway programs, we've got training tracks, we've got loan repayment, we've got Medicare and Medicaid funding, but we're not, and we've got actually the J1 visa program and the Conrad 30 program to attract IMGs into places, but we're not actually doing that much, which is why it's in gray, around physician retention initiatives and physician reentry. So I just want this to sit with you as it sits with me and think about, wait a minute, we're creating this incredible pipeline of nurses and pharmacists and physicians, but we're not paying attention to that middle or later part of their career trajectory where we are seeing burnout due to moral distress, and we're seeing retirement, we're seeing pressures from caregiving. People are exiting practice, but they're also trying to re-enter practice. And so one of the things that I've been trying to do is unpack this mid to later career behavior. So trying to understand the numbers of people who exit and re-enter and the characteristics of those people who exit. Why is this important? We'll talk about it in a minute, because if we know who's exiting, we can either try to retain them or we can try to recruit them back. These are, for those of you who love data as much as I love data and love things like odds ratios, let me explain what you're looking at. You're looking at data from North Carolina where we, I combined data from 2005 to 2024. And I looked over that period at physicians who retired, who indicated they were retired, or who said that they were temporarily out of practice, out of clinical practice. My model, it was a logistic regression that adjusted for things like time fixed effects to allow the fact that, over time, more people may be retiring or dropping out of practice. It adjusted for rural practice and, in fact, rural docs were less likely to retire or be temporarily out of practice. It adjusted for specialty. Primary care docs were more likely to be out of practice. It adjusted for which generational cohort they were in, whether they were boomers or Gen X or millennials. And it adjusted for their age and their sex. And one of the things that just popped out of this model was that female physicians in North Carolina are 2 to 5 times more likely in every age group of dropping out of clinical practice, either because they are retiring early. Yes, they are retiring early and in their 40s, or they're temporarily dropping out of practice, which is huge. And it signals to us that we really need to be worried about reentry. And the way that I make this case to policymakers is I say, this matters because you have up to 20% of your workforce in any given year that's inactive. So not only can we've talked a lot about retention, and retention is important in every kind of way for nurses, for physicians, for pharmacists, but let's not forget there are people who will exit practice. The big question is, how do we entice them back? And re-entry programs are expensive, hard to access, come with all sorts of regulatory barriers, hard to get stay board certified. So this is an area where I think the states and feds are going to be focused in the coming years. Okay, in my last couple minutes, I want to talk about all of the data that are underlying some of the things that I've just showed you. I'm going to show you 2 examples of data that we have, and then I'm going to talk about very briefly about some great resources you already have in New York. So North Carolina has built a really extensive data infrastructure and data visualizations. And we've done this to make sure that we're sort of the clearinghouse where people come to understand the state of the health workforce and engage policymakers. The first thing I'm going to talk about is our health professions data system. Our health professions data system, you have a link down here. Feel free to copy it. We'll send the link out as well. This actually houses data from 21 health professions in North Carolina online from 2000 to 2024. We actually house the data back to 1980, but the data are only online from 2000. But using this online tool, you can see the numbers per 10,000 population. You can see the percent of the workforce that's female, the percent that's 65 or older, the percent that comes from an underrepresented minority. And in fact, we have it so that the users can download the data. They can download the maps. And we did this because we wanted people to be able to put it into their presentations at the legislature, or if they were going to Raleigh or wherever they're going, to be able to have the data and be able to download it. We also use the data to continuously monitor workforce supply and highlight workforce challenges. So we did this analysis of all of our new dentists in North Carolina. Good news, we added 586 dentists between 2017 and 2021. Bad news, 60% of those dentists went to 5 counties in North Carolina. 60, and another 90 counties gained only 20% of our new dentists, and yet they represented 60% of the North Carolina's population. Modeling and having data like this is incredibly important to show where, in fact, your workforce is going, and in fact, they're not going to these rural communities. We generate blogs and interactive data visualizations, which I encourage you to look at on a wide range of workforce issues. Things like our CNM workforce, our certified nurse midwife workforce. We've been doing a lot on RN retention. In fact, it's going down instead of up. We've also done a lot of work on Hurricane Helene, sort of understanding the workforce that actually has left the state and may not be coming back after Hurricane Helene slammed into Western North Carolina. We also use the data to model supply and demand, and so we have a NurseCast model. NurseCast is an interactive supply and demand model. We've given you the link there to take a look at. And one of the things I'm most proud of is our graduate diffusion tool. So we actually are able to monitor where each of our graduates from North Carolina move after they graduate their nursing program. So how far do they move away from their nursing program? And I'll show you that very quickly in a minute. The workforce models we've developed are incredibly important to show and frame workforce problems and help policymakers target investments, right? So what you're looking at is our supply and demand projection for nurses in North Carolina. That upper line is the demand, the lower line is the supply. You can see under our baseline assumption, we were going to be 12,500 or 459 nurses short. But if nurses exit the workforce as they are earlier, our shortage actually almost doubles from 12,000 up to 21,000 nurses. Here, really showing policymakers and other decision makers, it really does, retaining your workforce really is important. And because when we go to the legislature, often the first thing they say is, well, let's build a new nursing school, let's expand nursing, graduates. And that is important. But I kept telling them, we're not going to educate our way out of this shortage. So this is showing, remember that 12,459 shortage I showed you. Even if we could magically increase our nurse graduates by 10%, we only close that gap by about 2,000 nurses. So you can see the effect of retention is much greater than graduating more nurses. And you can see the NurseCast diffusion tool where it displays the footprint of our education programs, allowed us to track, in fact, the retention in North Carolina of our LPNs and ADNs, seeing that the ADN, and this was something Mr. Simons mentioned, the ADN programs are much more likely to put their nurses into rural communities than our registered, our four-year registered nurse programs, and even higher for our LPN programs, the retention in rural counties. Last, I just wanted to show you, this is our grad diffusion tool where we actually track 5 years out or 2 years out where nurses are practicing. And, the UNC system has, I think, I can't remember how many campuses. I should know this. They'll probably fire me for not knowing. But anyway, we have a number of campuses, and 2 of them are at Wilmington and 1 at Pembroke. And you can see they're very different footprints, right? So UNC Wilmington retains about 85%, whereas Pembroke only retains 77%, but that's because Pembroke gets a lot of military nurses. But look at the retention in rural. Half of the Pembroke class is going to rural. So these are the kinds of things we track. Why is it important? Because then we can figure out where to be investing in the nursing workforce to address workforce shortages. So we have many more workforce planning tools. I'll share this slide, but I did want to highlight you all in New York have a premier Center for Health Workforce Studies that does just an incredible range of New York focused research. And so I just wanted to share some of their annual reports on the supply and distribution of health workers. We'll give you the URLs, the recruitment and retention challenges, and then the HPSA designation and service obligation programs. A lot going on. They also have a dashboard they just released, which is really neat to have a look at. And then they have a registered nurse education pipeline annual report and a physician resident exit survey, which is it's been since 1998. And so many of us have admired the work they've been doing to track annually where residents go. So just wanted to highlight some of your local resources right there in your own backyard, and also highlight there are 9 federally funded health workforce research centers. So if you have questions on allied health, you want to talk to University of Washington, oral health, talk to the folks at SUNY Albany, and behavioral health, we have a really great group here in North Carolina. So just wanted to share those resources with you, and thank you today for the chance to share what's been happening here in North Carolina, nationally, and New York as well. So thanks very much.
Thank you very much. We have a couple of questions in the chat to kind of kick us off, and then we'll invite other people to submit. One of them was the impact of Medicare and Medicaid, Medicare, I think they meant Medicaid, payments, especially in rural settings. So I think there is a tendency for more people in rural to be utilizing federal healthcare programs, I believe. Would either of you like to comment on the impact of Medicare and Medicaid on rural healthcare?
I mean, this certainly isn't an area of my expertise, but I think some of the concern is that people who, not necessarily the payments, but enrollments. So if enrollments are restricted, people still seek health care. If it's uninsured care, then the hospitals largely can, bear that burden. And so for rural healthcare providers who have a large or a significant portion of their care being funded through Medicaid, you end up with a potential circumstance whereby they're already not financially doing particularly well, and then this imposes an additional burden which risks pushing them over the edge. That's my understanding.
All right, thanks very much.
Yeah, this question of dentists not accepting Medicaid is an incredibly important one, and it is one that we've been tracking in North Carolina to really understand it. The reimbursements are relatively low, and dentists have more of a business model than other health professions, right? So they own their own practice, they own their own equipment, they're employers, and they're operating in a different sort of model. And so, you know, they have to have a fairly high volume of Medicaid patients to be able to make it. And if they can see it for private pay, it's hard for that. So I'm just explaining the business model of it, but we are tracking this to try to figure out how to incent more dentists to provide patient, care to patients with Medicaid. And in fact, we've been looking at the denominator of all dentists in a county and the percent that take Medicaid, and it's really compelling for our Medicaid program to see those data, as well as not just dentists, it's also all sorts of other providers who are in the area to be able to, whether they're accepting Medicaid patients. So thanks for asking that really important question.
The other question has to do with scope of practice, and this is kind of sensitive in New York right now, but there's a lot of effort that we could expand the capacity of rural healthcare if scope of practice for different disciplines was expanded. So I don't know if you have other states you could comment on, Dr. Fraher, or other ways where scope of practice has made a significant benefit to rural providers by making things more available.
There is actually a fair amount of literature that actually shows how scope of practice changes in different states actually increase supply overall and do change the distribution. So there is actually evidence. Now, when evidence meets politics, that's where things get more difficult. But I do think making sure you're aware of that evidence and actually just simply, and Jean Moore, who runs the Center for Workforce Studies in New York, may have more to say on this because she's actually one of the experts in scope of practice. If you look at dentists, it's the same issue around dental hygienists and dental therapists. So this is a fundamental question. And that's what I meant about the Rural Health Transformation Act. I think this federal administration is very pro expansion of scope of practice. So I do wonder how that's going to play out at the state level. I think it's a great question.
Sort of related to that is we had a Dr. Dewan spoke at our Rural Health Symposium about the fact that medical school graduates may not practice as soon as they finish, that they have to go on to residency, and you had that in your thing. What about if they could practice before residency? Would that enhance the capacity of rural, because not everybody finishes their residency. You're on mute.
Sorry, this is such a great question. And I didn't have time because I didn't have enough time to talk about some work we're doing on international medical graduates. So increasingly states are looking at ways to bring in a workforce for people who did not complete a US or Canadian residencies. For those of you who don't know, to get a license in the United States, you either have to do your residency at the United States or in Canada, traditionally. But starting with Tennessee and a whole other number of states have been working on this, is allow international medical graduates to become licensed after they go through a alternative pathway to practice. So allowing them under some supervised period of practice, under provisional licensure or temporary license, different states call it different things, to be able in that supervised practice to gain the skills that they need to actually enter practice. So you see some of this in some states under the assistant physician model, other states in terms of developing alternative pathways for people who have not completed residencies, either because they're an international medical graduate or because they just didn't complete a US residency. I think you've hit the nail on the head, Sarah, in terms of, again, they're recognizing this reserve labor pool of people who could be practicing. And because states have scope of practice authority, they have the ability to implement these things, right? So that's back to federalism. Like, what are the state roles and what are the Fed roles? Now, will CMS pay them? That's a federal issue. So as you're thinking through all of these levers, you have to think both the federal and the state implications of a change in policy and practice.
All right, thank you. That gives us something we might be able to look into. Other questions from the group? And anybody who wants to just unmute, you can do that too. We just got a new one, healthcare workforce in rural areas.
Yeah.
What work is being done to understand people with musculoskeletal issues? Is there data projects to bring care to people? Well, a data project. I'm not sure what that means, Marcy.
Brian, I think you're asking a really important question. Sorry, did you want to? I see.
I could probably speak it better than I can write it. So, yeah, so I'm wondering, with the limited capacity that we have and that you've spoken about, how are we diving in to look at, okay, there's a limited number of slots because each practitioner has a limited number of slots. And so how are we utilizing those slots? I'm actually a physical therapist, and so I do help primary care clinics say, patients come in with low back pain and neck pain. How can I help them manage that patient so they're not taking up all those slots for something so they can manage patients with other conditions? I hope that's a little clearer.
Yeah, Brian, what I see your question is really important that we don't ask here in America, but we ask, for example, I've worked for the National Health Service in England, and the question you're intuitively asking is, can we reduce demand on certain, scarce providers, right?
That's correct.
I love this question, right? So and I think, one of the things that we've been working with our National Health Service colleagues in England looking at is what is the role of physical therapists and occupational therapists and others in actually treating community-based conditions so that they don't end up in a primary care office with a condition that could have been dealt with by a PT or an OT or someone else. I think, intuitively, you're also asking this important question about sorry, I just lost it, but like even for behavioral health conditions too, we see this is like if we actually had behavioral health providers in the community who could actually address some of these things, people don't end up in the hospital. So I think you're asking that important question of how do we reduce the demand side equation through other healthcare providers and nurses. For example, sometimes registered nurses are doing things they should not be doing, right? They are, figuring out like they're doing all sorts of tasks that are really not, they shouldn't be doing, like ordering the patient's lunch or cleaning the room, right? Somebody else could be doing that so we can really preserve that scarce resource. I think that's a really important question. Like, what is the constellation of providers in a rural community and how do we leverage them in a way that actually makes sense from a workforce planning perspective?
Yeah, you nailed it exactly. Thank you.
And Marcy's question was really a little bit more on going back to the evidence base, like, can we demonstrate perhaps better health outcomes from having rural providers be more available locally or that kind of thing? Like, do we have that string that shows the connection?
Yes, and there is data like that. It does exist. There is evidence that people are healthier if they can get care locally, and especially for what we think of as ambulatory sensitive conditions, things that if they were treated in a community-based hypertension, diabetes, would not end up in an emergency room, right? Even dental abscesses and things that if we had a dentist wouldn't end up. So I think thinking about and analyzing your discharge, your hospital data in New York and thinking about what are the things that really shouldn't have ended up in the hospital? Where was this patient coming from? And were there providers in those areas? Yeah, telehealth.
Sorry. I was just saying, I think the past two questions are also related. So the lack of providers leads for offsetting care. Offsetting care increases the acuity of conditions, which then when care is sought, requires a higher level of a care and perhaps higher specialty care. And so like, it's all sort of systemic.
And I think the telehealth relates to that too. If you could provide telehealth as sort of an ancillary or supportive function, that then you can keep a person out of a higher level of care.
Yeah, for some things. It's difficult to do lab work through telehealth. A blood draw is increasingly sort of difficult in that. But yes, I mean, I think as part of the solution, particularly, for screening, behavioral health, there's been a lot of work in telehealth and things along those lines. So I think part of a solution, definitely. I do not.
Are there other questions or concerns that people in the audience would like to share? Here's a question about psychiatric.
Yeah.
mental health is pretty prone to being successful with telehealth, I think.
Yeah, Emma's raised, I think, a really important point here, right? Is that, you know, behavioral health providers, you know, LMFTs, licensed, you know, social workers and licensed professional counselors, you know, that's a really important point of once the prescribing and stabilization of the care plan has been given, to be able to deal with people in the community to reduce. That's a really good question. And
Pauline.
Yeah, hi, sorry, I wasn't sure if my question in the chat went noticed. I know we only have a few minutes. But were there any updates on improving broadband connectivity access in rural areas in New York? Whether yeah, phone and internet for either telehealth itself or any of the remote opportunities?
Yeah, so there's a state program, Connect All, and then there's the federal BEAD funding that have sought to address these issues. I don't have the data right in front of me, but there has been continuous sort of improvement. It seems like what's left right now in terms of broadband access are the most difficult places to reach. I know that there's a push right now to see if mobile broadband can be used in those areas, and there's the new sort of advent of satellite internet and things along those lines. So there are both state and federal programs in New York that are addressing rural broadband disparities, you know, but there's still work to be done.
Dr. Fraher, are there some examples in other states where they've changed licensure or facilitated in some way mobile clinics to make them easier to bring into rural areas?
That is outside my area of expertise. Sorry. I do want to address this question about if it's okay mitigating territoriality. I can say that word. This is where I do think having data is important. Data won't solve your problem, but I've been in the legislature so many times where people actually, the argument has been diffused and de-escalated by actually having data. People say, actually, this is what it looks like. I think is one important thing, but territoriality will continue to exist.
But we are running low on time now. Is there anybody else who needs to say something before we go to our closing slide? Well, I would like to provide a super big thank you to Dr. Fraher and Mr. Simmons for bringing clarity and depth to this conversation. What we've heard today reinforces that addressing workforce shortages in rural health isn't just about filling vacancies, it's about building systems that sustain access to care, strengthen local economies, and support the professionals who make rural health care possible. At NYSAR, this discussion doesn't end here. Our role is to translate insight into action. We do this by advocating for smarter policy, stronger pipelines, and collaboration across sectors to ensure rural communities aren't left behind. We encourage you again to participate in our Rural Health Day events on November 20th and to complete the webinar evaluation, which will be followed up in an email to you, plus it's in the chat. And we want to thank you all very much for coming, and particularly to thank Mr. Simmons and Dr. Fraher for your wonderful presentations today. Thank you.